Hello, am I audible?
Yes.
Okay. Uh, Good evening, everyone, and welcome to today's webinar on complex anatomy. And special thanks to Medical Aura community for organizing this amazing session. We present you a very amazing and educative session for today, which will not only help you to learn more about complex anatomy, but will also provide a valuable insight for clinical cases. My name is Dr. Vishakha Singh, and I'm host for today. Our next 60 minutes will delve into the intricacies of complex anatomy, providing practical tips and takeaways to enhance your clinical practice. And it is my pleasure to introduce our esteemed speaker, Dr. Mallika Banati ma'am. Dr. Mallika ma'am is a highly skilled professional in restorative dentistry and endodontics and dedicated to clinical excellence and patient care. Her expertise spans advanced root canals, smile designing, and precision restorative treatment. A university gold medalist with a distinguished academic record, Ma'am has also received the IACDE Young Achievers Award, demonstrating her commitment to advancing the field and achieving superior patient outcomes. Additionally, Ma'am has also several patent and copyrights under her name, a testament to her innovative approach towards dentistry. And without further ado, I'd like ma'am to just take over the session.
Thank you. Thank you, Vishakha. Am I audible?
Yeah, ma'am, you're audible.
I'm just going to share my screen, so just let me know if you can see that. It's a little easier.
Okay.
Is it visible?
Yes, ma'am.
Okay, so hello everyone. I'm Dr. Mallika Banati. Today the lecture will be on complex anatomy for the root canals. Is it moving forward?
No, ma'am.
Just a minute. I think it's loading. Yeah, I think it's moving now. Moving
Yeah.
forward?
Yes, ma'am. Yes, ma'am.
Perfect. So, hello to everyone again, and I'm Dr. Mallika Banati. I'm an endodontist who's a clinician now. My journey in dentistry has been shaped by a deep passion, which I share with all of you, I'm sure, which is endodontics, a field that to inspire and challenge me every day. From saving natural teeth to enhancing the patient's smile, endodontics, I feel, is just more than a specialty. It's art and science, it's everything. It's engineering, it's artistry, it's everything to me. And whether it's discussing intricate cases, exploring techniques, changing knowledge, I look forward to engaging with all fellow professionals, each one of you. You can reach out to me after this session or within the session if you have any further doubts. So I will be covering my topic under these headings. Basically, what exactly complex anatomy that we have. Every case could be a complex case or an easy case depending upon the expertise of an individual. I'll be dealing with two major complexities here, which is mostly curvature of the canal, and calcifications. If I have time, I'm going to cover radix as well. But if I don't, then I think we are going to have to take that in another lecture. So, coming to an introduction, understanding root canal anatomy is crucial in endodontics. Why is that? Because now we obviously have advanced CBCTs that we have for the study for morphology, revealing the complexity, which has accessory canals, isthmuses, fins, accessory canals. Earlier, we would just take up one tooth and fill it up, dig it up, clean it up, and fill it back. Now that we have CBCTs, the role of CBCTs, that is why in the position statement of AAE, CBCT is a mandatory before and after every root canal. So coming down to dilaceration, it was a term first used by Tomb. What is dilaceration? It is an abnormal bend in the root of a tooth or a crown portion. So, etiology, why does this bend happen? Now, everybody will not have this kind of a root or a crown. Why does this happen? So, it can happen because of a mechanical trauma to the primary predecessor tooth, an idiopathic developmental disturbance, a developmental anomaly to the tooth germ, the clefting, advanced root canal infections, and ectopic development of the tooth germ and lack of space. So the effect of anatomic structures, the presence of cyst, tumors, hematoma, mechanical eruption, tooth transplantation, all kinds of factors, they play a role for dilaceration. These are again pictorial representation of the same. We have a significant trauma such as intrusion, extrusion, avulsion, pathological structure such as abscess, tumor, cyst. All of these can again lead to a dilaceration of the budding tooth germ. Curved canals can be gradual curvature of the mesial canal or the apical canal in the apical portion, in the lateral portion, acute curvature in the apical third, curvature throughout the canal, a dilacerated root canal. We have S-shaped canals as well, which is a nightmare to the endodontist, um, because we have, I think, the maximum amount of file separations in such cases. So, associated syndromes. What kind of syndromes are associated with these kind of dilacerations? We have a Smith and Magnus syndrome, which is an autosomal dominant syndrome. Ehlers-Danlos, as we all know, Axenfeld and Rieger, and congenital ichthyosis. So root curvature may be apical in the apical portion, in the middle portion, a gradual curvature. As I will be sharing some of my cases later, you will be able to see. It could be a severe curve to a moderate curve to a straight curve, a bayonet, S-shaped curve, dilacerated curve. These are all definitions of a different type of curve that we have for a root canal. The root canals present as a challenge in cleaning and shaping, these kind of root canals specifically, and obviously the obturation again becomes a it's a concern. These curves must be valued and maintained strictly. So now if I am using an H-shaped file for a curved canal, what am I doing? I'm creating linear strokes and linear motions, and I'm straightening the path of that particular file. So I'm creating a single canal which is tapered and funnel, but I am not respecting the shape and anatomy of that particular canal. So these curves must also be valued and maintained strictly. Various attempts have been made for measuring the extent of curvature, and the most accepted theory is the Schneider's theory. So Gunde et al. Obviously, they included another term which is a canal axis angle (CAA), which is a parameter which provides more information about the coronal geometry. So now at the orifice where we are starting our working length, we start with taking the patency, start with taking a working length. So the first place at the orifice, how is that angle different from the angle at the root and the coronal edge angle, the cusp tip? That was defined by Gunde et al. As canal axis angle. So the epidemiology, the researchers have very different researches. According to some of the researchers, the prevalence is greater in posterior teeth, but according to a lot many, the prevalence is more in premolars and in anterior teeth. Crown dilacerations are far less common than the root dilacerations. Bilaterally occurring dilacerations might be seen in many patients. Those are associated with Ehlers-Danlos syndrome. So, diagnosis, failure to recognize the nature of the dilaceration is the reason of actual failure of the. So, basically, it's a multiplanar. If you can see this X ray right now, this X ray, if you can see, you can't see the root properly. But if you take a 3D image or you take a CBCT, then you will understand the root has a bend. It has bent completely at a 90-degree angle. So that is why a multiplanar nature of dilaceration is the reason why a lot of people tend to, you'll just leave it at a ledge, you'll make a canal orifice, and then, you'll separate an instrument and leave it at that clean and just obturate it till where it's open. That is what is wrong. This might contribute to the higher rate of unfavorable outcomes, such as separation of instrument and ledges, transportation, these kinds of unfavorable outcomes. So, what can we do? CBCT can be used to make a final diagnosis for such cases. So, access cavity for such cases, how is that to be taken? Access cavity approach. So, Lube noticed that an entire access cavity wall need not be extended. So, what you can do is you can just make a shamrock preparation, which is a minimally invasive preparation. If you know that this is our orifice, and you just enlarge at that portion instead of having down come through the whole wall from the beginning, you're reducing a lot of dentinal shells there, which is not necessary. So, the dangerous area, that is what is referred to as the dangerous area of the tooth. So, we need to preserve the pericervical dentine. So, what this cloverleaf appearance does is it saves the marginal dentin around, and it just creates a nice orifice right next to. It's known as a clover leaf because it resembles a clover leaf. So that is why just open the orifice there, have your file inserted, make sure that you have a straight line axis at some point, create a nice patency, and that is how you go about it. So, the root canal system might be blocked by irregularities even if the file is pre-curved because of the curvature. Hence, the use of a scout file is critical. The scout files are not only for measuring, they rather provide a critical information for shaping procedure as well. Another problem in endodontic treatment of these cases is the inability to continuously follow the curvature. So, maybe you've taken the patency, you have the working length in hand, and now when you start preparing, and by the end of it, when you put your master cone, you're about 2-3 mm short. I think we've all faced this in our clinics. So what do you do? Again, recapitulation is a must in such cases. Keep doing your initial apical file, a 10 or a 15 number, or whatever file that you're using. Keep re-instrumenting with that again and again. Keep irrigating, as Dr. Anu had mentioned in her lecture yesterday. Irrigation is a must. So this is exactly the file design. So the root canal system, the extent of pre-curvature, now how do you know how much curvature you need? So the curvature of the file will depend on the curvature of the canal. So curvature, the size of the instrument and the depth of the instrument at which we are going to use it. So mostly instrument with non-cutting tips are used. Night-eye files can also be used for curved canals because they have a non-cutting tip. All instruments that are used in a severely curved canal should be considered as a single use instrument. Please do not use them in any other case, they will separate. Sometimes, if the canal is an S shaped canal, there are very high chances that, for recapitulation, also you will have to take out another file for recapitulation. Do not keep using the same kind of file again and again. So, the self adjusting files have also been used for dilacerated cases, even though for evidence based dentistry, we do not have many studies regarding the same. So now coming down to a multi-visit approach should be followed for such cases. Why is that? Because you don't know what kind of remnant is under what kind of curvature. So it's a simple funda. Always keep it clean and leave it with an intracanal medicament just to be sure. So especially in the areas which are inaccessible instrumentation and irrigation, however much we clean, there is always about a 30 to 35% of substance inside which is not cleaned, which is known as a cyan collar. But it is very hard to clean these kind of areas only with instrumentation. So that is why irrigation is necessary as well. So then, because of that, the value of calcium hydroxide in endodontics is also very well documented, and obviously it is a medicament of choice. So, to overcome the complexity of reaching calcium hydroxide to the apical third of dilaceration, it has been proposed to mix calcium hydroxide with glycerin rather than water. So, like, with water, sterile water, or, distilled water, all of that is good only for regular cases. We mix it with glycerin for cases where we have dilaceration, for calcified cases, if you're, falling short of length and, you're not sure if your calcium is actually going to the right spot. So kindly mix it with glycerin and see the difference. In curved canals, now what are the challenges which are faced? Accessing the canals all without encountering procedural errors. These are the procedural errors that we face: gouging, furcal perforation, ledge, transportation, strip perforation, broken instruments. I think we all have broken an instrument in a curved canal. So now what do you have to do to not do that? So maintaining adequate working length and obturating to its full length. Prepare the canal to maintain the adequate size and geometry in all directions. The American Association of Endodontics considered excessive root canal curvature as an increased factor for affecting the treatment outcome. Hence, a CBCT before and after your cases is a mandate. Now, how do you determine the curvature? Before initiation of the treatment, an estimate should be made or as to the degree of curvature of canals by seeing the radiograph. So now we are going to take an interior angle. I'm going to obviously show you again in a pictorial representation that's going to make it a lot more clearer for you. The interior angle is formed by the intersection of a straight line from the orifice to the coronal portion of the root and another straight line from the apex to the apical portion of the canal. Now I'm going to show you, I think that'll be better so that it's easier. Classification of a canal curvature on the basis of location. It could be on a coronal, a middle, or an apical dilaceration. And on the basis of shape, now it could be an S-shaped root canal, it could be a J-shaped, a binet shaped, a C-shaped, which mostly you see in young adults, a binet shaped again. So now how do you measure the curvature? This is the most accepted method, which is the Schneider's method. So here we have the orifice. Here, the point A is the orifice, if you all can see. The B is the starting of the flare. So where your curvature begins, that is the start of the flare. And C is your apical foramen. So now what are you doing? You are creating a line, an imaginary line, passing through A and B, and then a line parallel to which passing through C. And the internal angle is the angle of curvature here. Now, how do you decide if the curvature is severe, mild, or moderate? If it's 5, less than 5, it's a mild curvature. If it's 5 to 20%, it's a moderate curvature. And if it's more than 20, it's a severe curvature. Now, similarly, Wien's method was a modification of the Schneider's method. They had the same things, but they did not take the angle here at. So, this was the angle that we were taking as an internal angle. What they did was they took a perpendicular from both those lines and took an angle on the inside of that edge, and they called that as the angle of curvature. So, again, the measuring parameters remain the same. So 5% is mild, 5 to 20 is about moderate, and more than 20% curvature remains severe curvature. Now, this Cunningham and Senior's method was an approach for a multi-curvatured root, something for an S-shaped root canal system. So point A was maintained for our orifice, for B was for the first deviation in the canal, C was for the second deviation of the canal, and D was the apical end at the canal. So now when you draw a line perpendicular to all of these, passing through A and B and passing through B and C and D together, the angle that forms again is the internal angle. We also have a coronal axis angle method. This method was particularly made for checking out the deviation between the orifice and the curvature. So the distance of curvature from the orifice was what was actually found out through this method. There was also an angle of abruption. Bliss did a lot of study on angle of abruption. We had an angle for abruption which was measured from the similar method, but this was for anterior teeth. So it was for a single canal. Straight line from the orifice was passed and one from the apical end was passed, and the angle was measured. Again, if it was 5% or lesser, it was a mild. 5 to 20 was a moderate curve, and more than 20 was a severe curvature. Hawkins' method was similar to the coronal axis angle method, but we just took an angle outside to that. So what did we do? We took a perpendicular line passing parallel to the line of straight horizontal line passing through the orifice and taken an internal angle through the apical curvature through there. CBCT method. Now CBCT has made our lives so much easier. So if you see the CBCT and you can draw a line passing through your orifice to the first curve and from the apex to the curve, and then draw an internal angle through that and measure that with a regular compass, and then you can check out for how moderate or severe that is. What are we doing? Why are we doing all of this? So now, according to Schilder, we had a mechanical objective of cleaning the root canal. So we had continuously tapering funnel from the apex to the axis cavity. A cross-sectional diameter should be narrower as going down at every point apically. The root canal preparation should follow the shape of the original canal. The apical foramen should remain in its original position. The apical opening should be as small as possible practically. And what were the biological objectives of root canals? So we should have confinement of instrumentation inside to the root itself. Do not over instrument and try to purge the periodontal tissue outside. No forcing of necrotic debris beyond the foramen. That is why I think we are always told to use a side vented needle to have a lesser of apical debris extrusion. Removal of all necrotic and inflamed tissue from the root canal space. Creation of sufficient space for intracanal medicaments. All stainless steel instruments to straighten upon bending are prone to transportation and ledging. So it is mostly said that use of hand files, the regular hand files should be used instead of using just the stainless steel, because the preparation is very less. Uh, at the same time, H files, like I told you previously, use in a linear finding motion. They straighten the canals, so are not very recommended for curved canal cases. Reamers and K files are so K files can be they are the material of choice for just taking the patency, but night eye files are the best. The undesirable shaping effect is given by the K files, which are titanium and aluminium, so they have a cutting effect as well. Flexible stainless steel instrument with a modified non-cutting tip removed the material equally well and performed better in curved canals because they're more flexible and chances of separation become a lot lesser. So now, how do you decrease the force on the file that you're preparing your canal with? So pre-curving the file is one way. So placing a gradual curve on the, so when you're actually going in for your instrumentation, you mildly pre-curve your file a little, and you can place a sharp curve at the file as well if you have a bayonet type of root canal. Extravagant use of a smaller number file, as they can follow the canal curvature better. So if you have a curved canal, try starting with 8 or 10 number file instead of a direct 15 number file, because obviously their flexibility is more until larger files are able to negotiate without any hindrance. Use of intermediate size of files, like I told you before, keep recapitulating. So if you're using your night eye files and you've reached till a 30 number or a 40 number, say, then you should try again recapitulating with a 15 number or a 10 number in between for a smoother transition of instrument size, because this way your apical debris extrusion is less, your preparation size remains adequate, your apical working width is not violated. Now, apical working width is a very long topic. I do not have time to cover the whole thing, but apical working width is what we aim to preserve for but that is what we look at when we are actually checking the tug back. So use of flexible instruments, as they help in maintaining the shape of the curve and avoid errors like a ledge, elbow, or zipping of the canal. Now, what is a glide path? The starting point of all root canal preparation procedures is the negotiation and securing of a smooth radicular funnel from the canal orifice to the physiological terminus. Now, that is the definition of a glide path. So, why is glide path necessary? So, this is basically, we are providing as the name suggests, we are providing a path for the other files to come and follow, so that you have that file and that is what you have to follow. That is the path file. So, coronal pre-flaring of the canal and the preparation of a glide path is suggested. Coronal pre-flaring, what does it do? It reduces the fracture chance of the instrument. So, now, not as though how we used to do earlier with the GG drills and piezo reamers, not that much, because that is completely against the minimal access rules that we have now. But we do have coronal flaring files, so use those with a good 17 by 3 and 19 by 3. That is what we have, and those are good files just to have a pre-flaring. A glide path can be prepared with a stainless steel K file or engine driven instrument as well. So it has been suggested that during the mechanical preparation of curved and constricted canals, no engine driven instruments should be used, whereas a hand instrument has not been placed before. So now, if you have a curved canal, and believe you me, with my experience, if you have an S-shaped canal, always go for a lateral compaction. Try to, or maybe like a hand pro taper. That is the best that you can do. But prepare fully with a night eye file till about 30-35 number, and only then insert your pro tapers, hand pro tapers. Otherwise, try and going in for a lateral compaction. Coming down to techniques for securing a glide path, how are we to secure your glide path? So, any narrow and curved pathway from the canal orifice to the radiographic foramen that blocks the negotiation of sizes 6 to 10 can be defined as a challenging glide path. So, now initially, only if you're putting your file and you have not reached your full working length or till the apex, you can imagine how tough that would be to negotiate that kind of a curve. Not like just by the hook of it, if you have to pre-curve and you have to go down and you feel some force, then exactly you have some kind of an hindrance in between. The canal pathway might be blocked with collagen, debris, fibrotic tissue, or calcifications. Follow gently and touch the blockage, remove the file, irrigate, recurve, repeat, and until the file moves deeper and cleaner and smoother. Now choose a smaller number file. If you feel resistance, do not push, do not force. Please, your file will separate in between. The diameter of the shaft of the file used might be wider than the canal dimensions, blocking the further negotiation. The solution might be to either change to a smaller number file or to something which is coronally restrictive. Now, what exactly how do you negotiate a glide path? So files larger than 15 become more rigid to work around the curvatures with, and it should be used with a balanced force technique, which I will be discussing later in my presentation. Negotiation can be done by a balanced force technique in such cases, and the curvature begins at the first level. Apical advancement should be done. The canal might split into two or more branches. Post that, irrigation must be proper. The canal might be constricted to a smaller size. There might be some kind of debris. That is the reason that we are not able to completely negotiate such canals. Now, what is a balance force technique? The balance force movements were introduced, which is to 60% clockwise as it binds against the wall and advances apically, anti-clockwise 120-degree with apical pressure so as to crush and break off the engaged dentinal walls. Then again a clockwise 60 degrees with apical advancement, allowing the flutes to be loaded with debris and removed from the canal. So basically the watch winding motion, but a little bit more enhanced from that. So you go 60, then you go full 120 back, and then you go 60 again and pulling it out. So now what are the advantages? It is efficient, less prone to cause iatrogenic damage to such cases, maintains the instrument centrally. So basically our instrument is centered within the canal. That is the first requirement of cases which have calcification and curvature. So extrusion of debris apically is also reduced in such cases, resulting in less post-operative pain. Iatrogenic errors can be reduced by decreasing the restoring force by the means of which straight file apt to bend against the curved dentine, decreasing the length of the file which is aggressively cutting in a given span. So now engine-driven instruments and curved canals. So during root canal instrumentation of curved canals, variations in pressure required for progression into the canal is almost threatening for the files that we are using. So mostly try going in for a hand file. If you are sure that your curvature is not so much and you can deal with the curvature like that, engine driven instruments can be used. The ability of an instrument to resist the cyclic fatigue has an inverse relationship with the square of its diameter. So the same inverse relationship applies for the flexibility as well. So that is why the night eye files are more flexible, but the cutting efficiency is lesser. So therefore, the smaller diameter tip of the file can negotiate an apical curvature easier than a larger diameter portion can negotiate the same amount of curvature. So now step one, what do you do if you're using an engine-driven system? Step one, determine if there is a curvature and how much the curvature is from the apex and from the orifice. Now divide the canal into zones. This is the zone technique. Dividing the canal into zones according to the location of curvature, that can simplify your preparation, with each zone having a different technique. So your curvature on the upper edge is maybe like say about 5 to 20%, and the second curve is more than 20, which is a severe curvature. So you can have a two-phased preparation for such kind of cases. So step two will be determine the distance of each of the files having different sizes and tapers that can safely be advanced to around curvatures, which size file will need to be used in the coronal zone to prevent any subsequent file from binding in the apical zone. We also have a reciprocating technique. With the introduction of a single file reciprocating instrument system was used, it was claimed that these are better, but we do not have any evidence based studies for these as well, because these are just claims. The instrument cuts dentin in a counterclockwise direction and are released in the clockwise direction. The instrument will progress into the root canal because the clockwise rotation is smaller than the counterclockwise. The releasing motion removes the stress from the instrument and prevents it from instrument fracture. That is how they are proving that, the reciprocation motion is better than the regular rotary motion. We also have a TCA technique, which is a tactile controlled activation, which I suppose as an endodontist we all have, and more so if you have, you have that tactile when you can feel the tug back, if you can feel the drop in that pulp chamber, you have a good tactile sense. So now defined as a single stroke activation of a motionless, which is stationary engine driven file, only after it becomes fully engaged inside a patent canal and tactile feedback of the underlying anatomy is then gained. So TCA fully utilizes activation only after maximum engagement of the file below the fulcrum of the curvature. So now it is divided into three phases: stationary, in-stroke, and outstroke. So stationary is after accessing the technical patency to the apical third is achieved. The taper of the first engine-driven file should be about 4%, not more than that. Kindly do not use your F1s for this. It is a 6%, 7% taper. Don't try that. For an in-stroke phase, before activating the file, it needs to be verified that the tip of the file has passed through the first curvature. Now, how are you going to check that? Please take an X-ray, or if you're sure your path, with the tactile motion that you have reached, or maybe with the working length, that how much are you exactly within inside of the canal. Once the file position is verified, the file is activated and then pushed slightly apically, which is the in stroke, as we say, until the activated file resists further advancement below the curvature is done. Outstroke phase is once the resistance is met and felt, the file is withdrawn from the canal without applying further any apical pressure in a single stroke. During withdrawal, the file can be pushed towards bulkier root structure away from the structure, thinning the danger zone of the teeth. So if you can see here, you are supposed to take it out from here. This is the danger zone here, as mentioned here, because if you're creating and you're trying to pull out the file in a single motion and it tries to cut the dent in here, the internal portion, so there's a very high chance of a strip perforation here, and that is exactly what we don't want for such cases. So now how are we to do disinfection in such cases? As Dr. Anu has mentioned about 3D cleaning and 3D shaping, it is advisable to use enhanced technique for such cases. You cannot just go around, injecting saline in your cases, and then the cases will definitely come back to you. Not maybe sometimes immediately, but in a year or two. Therefore, it is advisable to use enhanced techniques. New systems such as sonic, ultrasonic, now we have active pressure, negative pressure, all kinds of passive techniques as well. So the root canal curvature must be respected and limits the irrigant penetration during conventional irrigation. The irrigation efficacy is affected if the canal cannot be adequately shaped or if the needle cannot deliver the irrigant close to the working length. So a minimum 1 to 2 mm short, the irrigant must be put. You have to irrigate with a 5.25 sodium hypochlorite. There is that the importance has been discussed yesterday. So increasing the temperature of sodium hypochlorite might decrease its viscosity and improve the flow and effectiveness of the irrigant in the curved and narrow canals. That is what you can do. Also, we have PIPs, which is a different system, a passive system, and we also have gentle waves, son endo, which have been introduced for cleaning such kind of cases. They are negative pressure based techniques. So there was an article which was shared by Rosalie. They studied the efficacy of different irrigation techniques in a simulated curved root canal, and the study used a highly standardized experiment to assess the influence of degree of canal curvature. It was found that the degree of canal curvature had a significant impact on the debridement efficacy of irrigation activation techniques as well. So, different systems were used in this particular study. Now, what can we do in what is best in our hand? We have the hybrid irrigation protocol as well. So, sodium hypochlorite was used with the liquid EDTA 17 percent using side vented needles. After 5 ml of irrigation, ultrasonic activation should be done for 15 seconds using a stainless steel ultrasonic tip connected to the handpiece. Before 1 mm had doubled curvature, abnormal to the level of curvature without touching the canal walls to enable free vibration of the tip. So try going into good working length. Full might not be possible, but at least till the first bend of the curvature if you have two bends in the curvature. Sonic activation is then done for 15 seconds using an elastic polymer tip. This cleans the apical part which we have left. So why are we not touching the walls in the above safe method? Because there is heat overheating of the walls that can happen, and then there are chances of unnecessary dentinal cracks. That is what we don't want. Coming down to a pulp canal calcification, a pulp canal calcification could be considered as a radiographic observation of the appearance of root canal rather than a distinct condition. So, it is not called as a disease itself, it is just a condition. One or more pulp canal calcifications are present in at least more than 50% of all teeth. So sometimes, they go unnoticed because, we negotiate them without even knowing the fact that they are pulp canal obliterations. In the pulp canal, in the coronal pulp, the calcification usually takes the form of discrete concentric pulp stones, whereas in radicular pulp, calcification tends to be a little more diffused. So, calcific metamorphosis is also a term which I think a lot of you might have heard, or pulp canal obliteration is defined as the rapid deposition of hard tissue within the pulp space, often in response to trauma. So, what is pulp canal obliteration in detail? It is not necessarily indicative that you have a disease or something or a pathological state of tooth. Therefore, it is just a condition, not a disease. It may affect the diagnosis, obviously, and the treatment. If it is not diagnosed properly because of certain reasons, it will not be treated to its best potential. The pulp canal contained within a calcified canal can be normal or disease. That is, all pulp and root canal conditions should be associated with pulp canal calcifications. Luxation of teeth as a result of trauma may result in calcific metamorphosis, a condition that can, in a matter of months or years, lead to partial or complete radiographic obliteration of the pulp. So, if your tooth, has had a luxation, or maybe even for cases with extrusion or intrusion, there have been cases where the tooth has gone through calcific metamorphosis, and there is not even a single canal that you can see. If you can see here in this particular central incisor, you cannot see the canal. So uh, it is not possible to negotiate such kind of cases. It is very, very difficult, extremely difficult. I'm going to share one of my cases that I had got through. It was referred, but I will just show you. It was an absolutely difficult case because in such cases, the chances of going wrong are very high, and you're not even getting a start point. So you have to figure out when you're actually creating that access cavity, and you feel that ditch somewhere. When you're not feeling a ditch, how are you to penetrate any further? You're not getting an access opened anywhere. So these kind of cases become a trauma for a dentist. The cause of radiographic obliteration is excessive deposition, which is happens very rarely. Excessive deposition at the same part where you can actually see a pulp stone completely, or maybe morphosis. Except for the morphosis part, radiographic obliteration is not very clinically seen. So also there is a clinical guide to color change here, which I've put. So now how do you know where you are exactly when you're going deeper and deeper in the tooth? So you should know your enamel is white to grayish a little bit on the hue. When it's yellow, you're more in the dentin. The floor of the pulp chamber is gray. It's completely gray. Sometimes it's more of isthmus and fins. The root canal orifices will appear black or dark gray again, and the pulp stone will be pearly dark white or dark yellow, which will be right there in between. So now radiographic interpretation and findings. So pulp canal calcification is very evident. It can be seen in such cases. Like it could be partial. Like if you know, if you can start seeing here in this central incisor, it has been partly calcified here, but in this particular central incisor, it is completely calcified. It may involve the entire pulp space. Other radiographic observations will depend on the pulp or the root canal conditions as well. So associated periapical, periradicular conditions might be seen, and then as to judge what exactly your treatment plan will be. So you know, if there is something that you have to do with the tooth particularly, only then try and open such kind of a tooth. Otherwise, it is one of the contraindications of endodontics to deal with such kind of teeth until and unless there is any pain or any kind of symptom that the patient is giving. So EPT is the most reliable test for the pulp calcification. Calcification reduces the conductivity of the temperature. So the temperature change tests are not exactly recommended. EPT results must be interpreted carefully, as some teeth will not respond even though there is no pulp present. So there can be a false positive and a false negative in such cases too. Now, how do you manage such cases? So you have a CBCT that will help you guide through how long and how from where you are exactly, where can you actually find a viable canal. So you know, you'll have, then you can take in a guided access, maybe then have a dynamic system used for such kind of a case if it is completely mandatory. What does a CBCT do? It reveals the internal morphology. It will aid in evaluating the extent and the nature of the calcification. So now if it's completely calcified, so if it's showing you it's apically calcified, so you can open till where it's opening and then try and negotiate further. But if it's completely calcified, so then you're going to rethink on your treatment perspective as well. The depth of the calcification, or where is it found, like again I told you, if it's only at the coronal aspect, you know, you're going to break it with the ultrasonics, or you're going to try using the lasers for such cases, and then you can have your complete canal patency within the. So for long standing cases that have abscess and cyst as well, you have calcified canals, because it is the tendency of the pulp to, you know, provide less nurturing material to the abscess and the cyst. That is why our canal starts constricting when we have a cyst or an abscess near to the tooth. So a tooth that has, you know, has a abscess or a sinus tract or something, there are very high chances that these cases will have a calcified root canal. It might be very easy to, you know, locate them, but it will be very hard for you to actually maintain the patency, find out the full part apical calcifications in such cases. So now what do you exactly do if you have calcifications? So now, as we have seen for curved canals, I have told you what exactly you're going to do, you know, maintain the glide path, go down using a small file, then you know, maintain and take a balance force technique, doing the zonal preparation. So now for calcified canals, so the deposition of hard tissue within the root canal space is what is causing the obliteration of the pulp chamber. So measure the distance from the occlusal surface to the pulp chamber from a preoperative radiograph. Start with the small burr. So maybe say a number 2 or a number 4 round burr. Avoid removing the large amount of dentin. And always keep your water pressure on as well. I have seen a lot of dentists not using the water while they're using their air rotors for access cavity, because you know, they're like, "Okay, we don't have to preserve the pulp because we're doing a root canal." That's not the case. You are having the dentine chips stuck into the orifice shells, where, you know, locating a canal will be very tough for you if it's a canal calcification case. Start with the access preparation using a small burr, like I told you. Avoid removing large number of dentin. We have to maintain the pericervical dentin as well. If an orifice is present, start with the DG16 Explorer. Apply firm pressure and try to poke it in, and try to see if it's stuck there, if you can feel the catch there, if you can feel that it's actually stuck. That if it gets stick somewhere, that is your point of insertion for the orifice. At this point, you can place a number 8 or number 10K file or a pathfinder file into the orifice and try to negotiate the canal. Once the orifice has been located, a number 8 file is then penetrated into the canal to negotiate the calcified canal. So now if you've taken a number 10 file and it's not going full length, as you can see in the picture as represented on the side, so you know that this is the orifice. You're sure now that this is your orifice. Earlier though, you were not sure that this is your orifice because it was so calcified. Now that you're sure that this is your orifice, you've not reached the full length. So then you take up smaller numbers. You go in with a 8 or a 6 and then start, put EDTA, put your sodium hypochlorite in such cases, and then start moving forward apically. Once the orifice has been located, a number 8 file is penetrated into the canal to negotiate. Use of night eye files is not recommended in canal calcified cases. It is completely contraindicated. Why? Because there is no strength in those files. Those files they will follow the paths that you give. But for in such cases, we need strength, right? We'll be trying to poke in every particular direction and try to force the file into the canal a little to see if it's getting stuck somewhere. But that can't happen with the night eye file. Your file will separate. Forceful probing of the canal with fine instruments and chelating agents can obviously refer to as formation of a false canal. You'll have a transportation. That is not something that we want. Allowing NaOCl to remain in the pulp chamber may help locate a calcified root canal orifice. Why is that? Can anybody tell me? Why exactly NaOCl to remain in the pulp chamber may help you locate a calcified root canal? It is, I'm going to give you a hint. So it is a test. It is a test that we do. So if any of you can tell me later. So now coming down to these kinds of cases, severely calcified teeth are predisposed to tooth perforation during pulp chamber access or initial location of the canal. Attached stones and they actually prevent the easy passage of explorers and endodontic instruments down the canal. So this is the case that I was particularly talking about. This has been my case. It had been referred to me. Look at the case already, that how it had come. So, can you see this small fragment of instrument which was lying there? And can you see these lines here which are going? I did not know what exactly this is. I thought it's some kind of an artifact, maybe while I took the radiograph. But as I started the case and I tried to negotiate, these are what my files look like. So, this had been a false alarm for the orifice. The previous dentist must have tried, and this is how the case looked like when it came to me. And now I tried to negotiate this. It took me a lot of time, a lot of liquid EDTA, and a lot of sodium hypochlorite to actually negotiate these kind of canals. So until and unless it is absolutely necessary, this was very necessary because it was an old patient and they needed a bridge in the front because they did not have posterior teeth. So this is all they had. And so, having to do a file retrieval from the periodontal aspect, then having to negotiate for the calcifications, it is a very tedious, cumbersome process. And again, but what I followed was the simple process. I tried to figure out the patency with a 10 number file. Once I was sure that I'm in the orifice, then I put myself then I used the 8 number or a 6 number file to go down to the full length apically. So in 2015, the American Association of Endodontists and the American Board of Oral and Maxillofacial Radiography updated their guidelines on the use of CBCT, like I already told you. They recommended the CBCT imaging for the location of calcified root canals because of high level of difficulty associated in these kind of procedures. The difficulties such as, obviously, because the treatment outcome becomes very dependent on such cases. Now for this, it was a Bertucci's type 8 curved canal case. Now again, if you see, the curve is, it seems very mild, though it was not very mild here. The preparation was again done through a 4% taper, 25 number. With this case, we had an MB2, curved canals, simple case again. Did a normal glide path, had my working length, took my master cone, prepared the files. I prepared the curved ones with night eye, and then used my rotary instrument in that. Now, this is the C-shaped type of curve that I was telling you. These are mostly found in traumatic cases or cases where, you have young adults where, you have some trauma associated with the tooth where it had been in that growing age. So you see the pulp polyp. I removed the pulp polyp with the laser, and you have your patency maintained with the normal files. Master cone was taken. It was a single cone obturation. So the C type of curves are not very difficult to manage. But yet again, I just had to put this case. It's special to me. Coming down to this case, this was a case of radix, and I'm not going to discuss the whole thing. I think we don't have the time for that though. But yeah, so there is this particular case for radix. If you can see the curve here, if you can maintain and see the curve here in the distal part, it's exactly a 90 degree bend. So to maintain that, again, what I did was nothing, keep recapitulating, have your 15 number, 10 number files used between every file that you're using. And then this was again a rotary preparation that I had done. And for the part in the apical, I made sure to have enlarged my apical portion with the hand files. Now, this is the calcification case. Again, another calcification case. If you can see a case here that I have shown, I couldn't see the canal possibly. It was absolutely very tough for me to even see the canal. But again, this patient was in pain and was not wanting to, let go of anything. It was a periodontal abscess as well. So we had to do the immediate access. I did the immediate access. I could locate the orifices, thankfully, but only the orifices. So now to negotiate the orifices took a very long time. But again, thankfully, I could use DG16 with my magnification, under magnification. And then it becomes a lot easier with magnification and lighting illumination. So now dynamically versus freehand access cavity. This was again a study done by Samir Jain, and the study navigate the dynamically navigated accesses resulted in significant lesser mean substance loss in comparison with the freehand technique. So now dynamically navigated accesses were also associated with higher optimal precision drill path to locate calcified canal in comparison with the freehand technique. So now freehand, there is obviously more chance of loss of dentinal structure, the cemental structure, cemental tears, these kind of things we do not want. So now if you have a dynamic or a static navigation for that matter, now what is the difference between a dynamic and a static? I don't want to get into the details, but dynamic is real time. So that gives you exactly optimum amount of, bend that you have to make to your file if you have to reach that point. So that is exactly, I am going to have to conclude now. Dilaceration. Dilacerated teeth are not common, but they pose a number of diagnostic, management, and prognostic challenges to the practitioners. And calcification, on the other hand, being a rather common finding, but again, very hard to manage sometimes too. But once identified, the defect of endodontic and restorative management of these tooth can be fully assessed. These are my references, and I would definitely want to let you all know. Always remember that the expert in anything was once always a beginner. And thank you.
Thank you so much, ma'am, for navigating the complexities of anatomy with us today. And if there's any doubt, we'll just take it now. Okay. I guess we are done for the day. Thank you so much, ma'am. And it was a very engaging, informative, and it will be undoubtedly impact our clinical practice as well. And thank you all for joining us today. We hope that this session will be helpful to you all, and you will just apply it to your clinical practice also. And thank you once again, ma'am, and thank you everyone for joining us today. Stay updated, stay informed, and keep learning. We'll see you in the upcoming webinars.